Okay, Assalamu alaikum, good afternoon. Happy to be with you today. And we are going to discuss one of very important topics, focusing on EMR effort to prevent the spread of HPV virus. And it's a timely discussion. Recently, the EMR region disseminated the new strategy for cervical cancer elimination, which is one of the very painful outcome of getting the infection of HPV, but also the global strategy and regional strategy that bring a lot of hope that we can start talking about elimination of cancer. And I think the discussion also come timely because this is March, and March is Women Month. It's a month where the HPV Awareness Day, it's a month of Women Day, and it's a month of Mother's Day. So happy Mother's Day for all. And we are luckily have very recognized, distinguished expert in the area from the global and regional level joining us in this webinar. So we have Professor Marion. She is Executive Director of Australian Center of Prevention of Cervical Cancer. She will bring her insight from this lengthy experience, 20 years of experience leading the laboratory population health and digital health, focusing on control of cancer. And she contributed a lot in this area in Australia, New Zealand, and Ontario. And she is currently chairs the working group in the review of Australian guidelines, management of screening and detecting abnormalities, the National Cervical Screening Program, and she is appointed as a member of the Order of Australian on the Australian Day 2020, the outcome of her significant contribution in cervical cancer screening initiative in Australia. So Dr. Marion will take us through an overview. Well, hello, and happy to have you, and we are honored to have you with us. And Professor Marion is going to take the overall overview about the issue and from the global perspective, and also from her exposure. And she was actually provided a lot of support even for our region in the development of the regional strategy. So she knows well the context in the region, and she will share some experiences from the other regions through her presentation. So floor is yours, Professor Marion.
All right. Apologies. I just was not on, I was still on mute when I went to screen share. I'm so sorry for that. Thank you for that very warm introduction. Can you hear me now?
Yes, loud and clear.
Amazing. So sorry for that. I want to just start by acknowledging that I'm coming to you from the lands of the Wurundjeri people of the Kulin Nation. Those are the First Nations people from here in Australia. And it is our custom to pay respect to elders past, present, and emerging. In this presentation, I want to articulate the global burden of cervical cancer caused by HPV, the progress towards elimination, and then some of the preventative approaches, just to set the scene for this evening. So in the most recently available data in 2020, over 600,000 women were diagnosed with this cancer worldwide, and more than half of them, 342,000, died from the disease. Almost all cases of cervical cancer are caused by persistent infection with the high-risk types of HPV. And this cancer, this tragedy is all the more so because it is preventable through vaccination against these types of HPV and screening for HPV to detect pre-cancer or early cancers at a stage where intervention is effective, either to prevent the cancer entirely or to effectively treat the cancer. High incidence and mortality rates are occurring very inequitably on a global basis, as you're seeing, with about 90% of cases occurring in low and middle income countries because of lack of access to these important preventative strategies. And this atlas of the world shows the burden of cancer, particularly in sub-Saharan Africa, and also particularly in my part of the world, in our nearest neighbour, Papua New Guinea. So this inequity is in all regions of the world, and is troubling. This particular graphic doesn't show it, but we also have inequity within countries, and certainly in Australia, our First Nations people experience cancer at more than twice the rate of other Australians, and they die of this cancer almost at 4 times the rate. So inequity is global, as you see here, but in most settings, it's also occurring within countries. And that same inequity is seen here in the mortality rates from cancer. Again, this domination in sub-Saharan Africa, some parts of South America, and in Papua New Guinea and some of the smaller member states of the WIPRO region. Some of these island nations have very high rates as well. So you will have noticed that your region, the Eastern Mediterranean region, appears to have quite low rates of cervical cancer. And that's a very, very good thing. Although what we do see in the Eastern Mediterranean region compared with other parts of the world is a somewhat higher rate of mortality to incidence. And this might be consistent with a degree of underreporting of incident cases of cervical cancer, but certainly suggests that when cancer is diagnosed, it's at a later stage and treatment is not as successful. So work could be done to reduce that mortality ratio in the region. So the background to elimination, everyone will be familiar that back in 2018, the Director General, Dr. Tedros.
Still ما في I'm not assigned as an interpreter يعني لسه.
Announced a call to action in calling for a cancer we can overcome. And one woman dying of cervical cancer every 2 minutes is a tragedy that we can prevent. So following on from that, we had the call to the actual strategy to eliminate this cancer, and we had the setting of the target 4 women per 100,000 in every country in the world in the next 100 years. So I just want to reinforce the difference between elimination and eradication. We use the term eradication to refer to permanent reduction to 0 in the worldwide incidence of an infection. And of course, once that infection has been completely eradicated, we don't need prevention measures to continue. Elimination is defined by the WHO. There are 3 categories, and we're interested here in elimination as a public health problem. And this is the achievement of clear and commonly agreed target definition. And this, of course, is where the 4 per 100,000 comes in. So how was that target and the strategy, how did they come about? Well, firstly, the targets are the so-called 90, 70, 90 targets. We're looking to put countries around the world on the path to reaching elimination by the end of the century, by 2030 to be on the path to elimination, to have achieved 90% coverage with vaccination of all girls by the age of 15, 70% coverage in screening, where women are screened with a high performance test by age 35 and again by age 45. So 2 screens in a lifetime. And what do we mean by a high performance test? Well, if you read the WHO publications carefully, you'll see that that means a test with the performance of an HPV test. And that definition is there to allow for the development of other tests that might have better performance or have the same performance but be more affordable or more practical. So at the moment, effectively, we're looking for HPV test coverage in that target. And finally, 90% of women identified with cervical disease should receive treatment, whether that's a pre-cancer or an invasive cancer. And this is a simplified version of the modelling that supported the establishment of the targets and the threshold of 4 per 100,000. If we look at cervical cancer rates and we keep doing what we're doing globally, we'll see this very slow drift downwards, and we will see continuing high rates of cervical cancer and continuing inequity. And if this was a chart of the number of cases, we'd actually see a growing burden of disease across the world as population increases. What you can see here in the red line is if we just focus on its own on vaccination, we can get there. But if we add intensive screening and vaccination to vaccination, then we save these additional lives and cancers here. And here we have probably estimates are at stake for the lives of 14 or 15 million women globally is the difference between relying on vaccination and waiting for those vaccinated cohorts to come through versus offering adult women globally who are alive now, who have missed the opportunity to vaccination protection through screening. And so on this basis, the WHO has made the recommendations I've articulated previously. So these preventative approaches, vaccination and screening, are here, and this slide is taken from your regional elimination strategy. It was our absolute privilege to support the regional office in development of the strategy. And of course, the strategic actions are aligned with the 3 pillars, together with health system strengthening and improving communication, advocacy and social mobilization, because as you'll see in some of the barriers to come, this is going to be important even when access to vaccines, HPV tests and other things can be mobilized through budgetary commitments. We still need the community to understand HPV, destigmatize HPV, which is a very common infection, and destigmatize this cancer. So I'm going to focus my further comments around the strategic actions 1 and 2, vaccination and screening. And this again was part of the information that we put together to support the development of your regional strategy. And of course, we had 20 of 22 member states responding to surveys about the various barriers to the elimination. And here you see the barriers to establishing an HPV vaccination program. Vaccine hesitancy is important, an important barrier, and we do need to, as I said, have that advocacy, and we need to destigmatize this infection and have parent and community confidence and community leader confidence in the HPV vaccination program. But an important barrier is also the cost of the program. And I want to talk briefly about an opportunity to address this barrier. WHO guidelines recommend that the target age group is girls aged 9 to 14 years. And the current on-label recommendation is a 2-dose schedule with the minimum interval between the first and second doses being 6 months. They are also saying, as you'll see, that there is this possibility for the off-label alternative single-dose schedule in girls and boys actually up to the age of 20 years, and saying that this regimen has a comparative efficacy period of protection to a 2-dose regimen. I'm going to show you some more evidence about that. Importantly, those who are immunocompromised, particularly those who are living with HIV, should continue to receive at least 2 doses. However, there is emerging strong evidence of the efficacy of single-dose vaccine, and data accumulated to date from clinical trials and high-quality observational studies is providing strong evidence that the single dose could substantially reduce the incidence of HPV-related cervical cancer and shows comparable efficacy and effectiveness between single and multi-dose schedules. And you see here the ongoing publication by the Single Dose Consortium, and that document can be accessed. It was last updated almost a year ago now, but will be further updated. As you can see, they are tracking a number of clinical trials that are beginning to report their results. And you can see there the summary of these 4 important trials showing comparable efficacy and comparable immunogenicity. And this is important because this single dose delivering high levels of protection, similar in magnitude to multi-dose regimens, looking at about 98% efficacy for preventing persistent HPV-16, of course, the most oncogenic type of HPV, or 18, with a single dose. Single-dose regimens can represent significant cost savings and can help with overall delivery charges, at least 30%, because of course you have the cost of the vaccines themselves, and substantially decrease the costs of the delivery systems required to get 2 doses into the arms of these girls. Single-dose regimens are going to promote global health equity, with 90% of the cases that could be averted over the next 100 years by moving to this regimen being in low and middle income countries. And this single dose regimen will increase access and uptake and of the cervical cancer deaths to be avoided in the next 98 years by reducing to 2-to-1 doses. We're looking at 64 million cases, which is astonishing. Acknowledging that although the supply constraints of the vaccine are starting to be eased, then even using the vaccines we've got, regardless of cost, across twice as many girls will lead to saving many, many more lives. So the most recent WHO update on the recommendation, the recommended schedule is a single dose, as I've said, provides comparable efficacy and durability of protection to a 2-dose regimen. Between 2019 and 2021, the coverage of the first dose in the pandemic has fallen. We were building towards quite solid global coverage, and we've gone backwards. So the optimization of the schedule is expected to improve access to the vaccine by offering the opportunity to expand the number of girls who can be vaccinated and alleviating the burden of follow-up required to complete the vaccine series. And I'm very pleased to say that in a high-income country like Australia, our government has been persuaded by this evidence. And in February, our Minister for Health announced that we this year, our school year this year, have switched from a 2-dose to a single-dose regimen in support of global efforts. So I'm really pleased that we're doing our part and not using too many of the doses unnecessarily, freeing those doses up for other parts of the world. Turning to HPV testing, these are the barriers that were articulated by member states from from the region, and cost of the tests and a lack of existing program structure really topped the list. Cost of HPV tests is starting to come down, and particularly for tests that are performed in laboratories, there is the opportunity around the world for PCR platforms that have been installed for COVID testing or SARS-CoV-2 detection to be repurposed for HPV testing, and that's an important opportunity for countries. There are a range of other barriers to cervical screening, including cultural acceptability, health services demands, a lack of laboratory capability I've touched on, and a lack of political will, and importantly, a lack of acceptability of provider-collected screening tests to women and their communities. So I just want to talk about WHO guidelines for primary screening. You will know that the WHO now is recommending HPV DNA detection as a primary screening test rather than cytology or VIA. And either clinician-collected or self-collected samples are appropriate, and I'll say more about self-collection in a moment. In settings where cytology is established and quality assured, WHO recommends that this continue until DNA testing, HPV testing is established. And I'm proud to say that in Australia, we switched to HPV primary testing a little over 5 years ago with a 5-year interval. So we've had our first round of screening with HPV. We wanted to be the first country globally, but we were beaten, I have to admit, by the Netherlands, who got there first. WHO is recommending a more rapid transition from VIA testing due to the inherent issues associated with achieving consistent quality and performance, but is not suggesting that existing VIA programs should be stopped. This recommendation is consistent for the general population and for women living with HIV. The guidelines, the WHO guidelines, are quite comprehensive and provide countries with a range of options on the screening algorithm that is sensitive to the available resourcing, from the screen and treat, which is appropriate in a low resource setting, particularly in remote communities. It can get around problems with loss to follow-up for screen positive individuals, or screen triage and treat for the general population. For women living with HIV, regardless of their setting, WHO recommends screen triage and treat because of the high rate of carrying HPV in those women and the risk of overtreatment for that population. The screening interval with a high-performance HPV test is every 5 to 10 years, or at least twice in a lifetime, as was modelled at 35 and 45 years, and more frequently every 3 to 5 years for women living with HIV, starting from the age of 30 or from 25 years for women living with HIV. So as part of the preparation for your strategy in the region, the survey showed us that current cervical screening around the region was highly variable, and only 5 countries had implemented a national program, although many had subnational programs, and that's a good place to start to build on. You can see there that while in some countries there was quite good coverage of screening, in other countries there was very limited screening coverage. Why do we recommend HPV primary screening? This is an analysis of what is now an old clinical trial that was carried out in Europe, showing a consistently low 6-year cumulative incidence rate of CIN3+, the important pre-cancer, among women who are negative for HPV. So here you see in the trials, amongst those who were negative for cytology, HPV, or both at baseline, those that were negative at cytology had a much higher rate of developing CIN3 across 5 or 6 years than those who are HPV negative. And the important takeaway here is that this negative predictive value is what allows us to lengthen the interval. And I think sometimes when countries look at the HPV test, they forget about the cost of needing to do cytology every 3 years. And they compare the cost of one test, cytology, against the HPV test, and they don't look at the cost of the whole program, including the necessity to screen very frequently, which in itself is quite expensive. After a further time, these data matured so that we could see the outcomes for cancers. And here you can see that amongst all randomized women, the cancer rates were quite low, but the control arm, those screened with cytology, had more than double the rate of cancer than the experimental arm, those screened with HPV. And here you see the cancer rate amongst those who had a negative result at entry. And for the development of cancers, you can see that in the first 3 years, the rates are extraordinarily low and very similar between the two arms. But over time, as time goes by, you see these two arms separating and with consistent low cancer rates in those screened with negative with HPV, as opposed to those negative with cytology. So further strengthening the evidence that HPV testing is a much better screening test, even at the longer intervals. And this needs to be remembered when comparing the costs of the two tests. I want to turn now to HPV self-collection. HPV detected in a swab taken by the vagina, from the vagina by a woman herself, is accurate and acceptable new screening tool that we think will scale up towards helping us reach those elimination targets. This is a Copan flock swab. It's the swab that we commonly use. It is extremely inexpensive. We used them during the pandemic. We chose them in our initial validation studies because they're widely available in our primary care sector for a range of uses. To summarize the evidence of accuracy, this is a very important landmark meta-analysis by Mark Arbon and colleagues from Europe. And essentially, what was found in the meta-analysis is that self-collected samples were not significantly different from clinician-collected samples, not for the detection of HPV, but for the detection of precancer SIN2+, which is really important when tested using a PCR-based HPV assay. There are some assays, as you'll see, where self-collection is not equally as sensitive, and they probably shouldn't be used in the context of self-collection. The evidence further showed that HPV self-collection is generally more effective at reaching underscreened women than sending invitations in a high-income country setting, and a very high adherence rate to follow up amongst those with self-collected sample that tested positive. So these are the data from that meta-analysis. These are called receiver operator curves, where we plot the sensitivity of the test versus 1 minus the specificity. So the best ideal test is up in this top left-hand corner with 100% sensitivity and specificity. And here in orange, you see the clinician-collected sample and the self-collected sample for these assays that are based on signal amplification. So the Digene hybrid capture 2 assay and the Savista assay, I think that's no longer available. However, when you look at those that are based on PCR, you see these very close lines and these almost indistinguishable confidence intervals here, showing the very similar performance between self-collection and clinician collection. And this means that we can offer self-collection to any women, not just the underscreened. We use self-collection in a project in Malaysia, collaborating with our partners there, addressing barriers to screening. These were patient barriers and health system barriers. Finding the room and privacy to undertake a pap smear was very challenging. We switched from pap smears in the initial study to self-collected swabs, and we supported them with a digital health platform. And the results were, as you see here, in the Malaysian setting, 5.5% were HPV positive. This is a little bit lower than general global rates of HPV, very low inadequate sample rates. And on average, it took 11 minutes to counsel a woman, give them the swab and get the woman to take the swab herself. The acceptability figures you see there. And this project has now built into a program supported by the Rose Foundation in Malaysia and has now screened over 20,000 women by this not-for-profit organisation. And we collaborate with the University of Malaya in running this. So this demonstrates how self-collection has really overcome some significant cultural barriers in Malaysia where women were declining pap smears. So self-collection is going to be the key. Through its accuracy, it gives us this effectiveness. I haven't shown the data, but we've demonstrated stability for 28 days at very high temperatures and humidity. And this is great for sending swabs to laboratories and enables flexible delivery. We can do lab-based testing or point-of-care testing with self-collection. It overcomes cultural barriers to screening. It can facilitate scale-up by freeing up our trained medical and nursing workforce to examine women in whom HPV has been detected. Those in whom it hasn't been detected are often only seeing a non-nurse or doctor, a health assistant instead. And by facilitating this scale up and by overcoming cultural barriers, it's a key tool to improve equity within and between countries. So this is my last slide. There are important opportunities to move the dial on cervical screening and HPV vaccination. Countries should be up to date with the recommendations about a single dose schedule, should understand that HPV-based strategies in screening strategies enable a much longer interval than other methods, and for this reason have been found to be cost effective in all settings, including low and middle income settings. And self-collection is an exciting opportunity to overcome patient and health system barriers to screening. So thank you very much for your attention. And I apologize for a few stumbles. It's just after 1 in the morning here, so I'm doing my best. Thank you so much.
Thank you so much, Professor Marion, for actually joining us despite this time difference. We are really appreciate. And actually we appreciate that you responded to our emails and our requests, and we were very keen to have you because of your expertise in the area and from in different countries. So if you have any question, please put your question in the Q&A, and then we will take it in the Q&A session at the end. So after the discussion and having this very comprehensive and having this recent update from the global perspective, and also have some insight from the support that the Australian Institute and Professor Marion did for the region. We have some insight, but we'll complement this by the presentation that we are going to hear from Dr. Kamal Fahmy. And Dr. Kamal Fahmy is a well-known public health expert in the region. He's the WHO medical officer at the regional office at the EPI team, but also he is now bringing extensive experience supporting different countries. He had worked in different countries, very challenging country, Afghanistan, Pakistan, and also Egypt. And in addition to his work in the regional office, Dr. Kamal had a PhD on public health and occupational medicine, and also he's had a lot of publication that informing actually the public health in the region. So we are expecting Dr. Kamal will take us more in depth in the region, how is the situation in the region, the progress that we made, and he will be more focused also in regarding the challenge of introducing HPV, where our region is looks behind the other region in this. So floor is yours, Dr. Kamal.
Thank you very much, Dr. Nada, and I'm very happy to join this very important forum, giving a quick update on the regional situation related to HPV introduction. So I'll try not to be very long. I'll try to be focused on the situation in the region related to the HPV introduction in the light of the cervical cancer eliminative strategy at a regional level. So in the presentation, we will be talking quickly on the global and regional cancer cervix elimination strategy, the global perspective for vaccine introduction, the regional situation on the HPV introduction up to this month, the country's efforts done in HPV introduction, some concluding observation, and the way forward. As you all know, and this has been mentioned, we have a woman dying out of the cervical cancer every 2 minutes, which is a real strategy, which this strategy is forcing everybody everywhere in the world to start thinking about how we can effectively prevent this deadly disease, knowing that there is an effective preventive measures for it. However, if we go in the EMR region, we find that there is a 1 woman dying per hour in the Eastern Mediterranean region. As you all know, this is the vision of the global strategy for cancer cervix elimination, having a world without cervical cancer with a threshold, as it has been mentioned, to reach less than 4 cases per 100 women a year. And we, as you see, we have 3 pillars in order to be able to do this cancer cervix elimination and reaching our goal by 2030 is 90% of the girls having been fully vaccinated by HPV vaccine by the age of 15 years, 70% of women screened with a high precision test at 35 and 45 years of age, as well as 90% of women identified with cervical disease receive the suitable treatment and care, which is really a very costly intervention in this disease with a very high mortality. We need actually, according to the SDG 2030 target 3.4, is to have 30% reduction in mortality from cervical cancer worldwide. We need here in this presentation, although we have a very good collaboration and strong coordination between the immunization department and the non-communicable disease prevention department taking care of the 2 other pillars of the cancer cervix elimination strategy, we are working together in order to reach all countries in the region and to support them in the 3 pillars together. However, here I'll be focusing on introducing this HPV vaccine, which is not a regular vaccine for us. We are used to the routine immunization schedule of vaccination among children. And then later on, we have been expanding our scope of vaccination to reach the life course, including the HPV introduction. But knowing that the HPV vaccine has its own peculiarity, we have some kind of barrier and challenges we are facing in order to be able to really, by this pillar alone, to avert more than 45 million deaths over the next 100 years. It has been mentioned actually many times, what could be the program? What are the programmatic issues related to the relay and delay of the HPV introduction in our region? So when it comes to reaching this 90%, which is really ambitious for our region, but not only our region, even other regions which have preceded us in introduction of this vaccine, they will have really hard time to reach this very ambitious goal to have 90% coverage among children less, or among girls less than 15 years of age. Vaccine hesitancy or stigma or safety or lack of knowledge, lack of awareness in one hand, and the cost of the program in HPV is in another hand, two main important factors which are preventing us from having this vaccine introduced in our region. That's why we need to work on acceleration of this HPV vaccine introduction in these two modes. Tackling the first mode related to lack of awareness and maybe religious context in one hand, and in another hand to overcome the cost of introducing this vaccine. But every day we know more manufacturers coming in the scene with a less costly vaccine, in addition to the new SAGE recommendation and new WHO position paper, informing with actually comparative efficacy and efficiency of one dose of HPV vaccine. On the other hand, when it comes to cost, we are working closely with donors. We have in our region 7 Gavi eligible countries who are benefiting from a generous support for HPV introduction in those 7 countries. However, these 7 countries still have some problem in relation to sustainability and maintenance of the cost after being graduated from Gavi, because Gavi eligible country today, this doesn't mean they will be remaining Gavi eligible country tomorrow. Also, there will be no problem related to the cost of the vaccine in the 6 high-income countries in our region. But for the middle-income country, there is a huge burden of cost. That's why, with collaboration between WHO and donors, especially Gavi, we started to implement a specific program of Gavi support related to the cost of this vaccine in the middle-income countries, and then we have 6 income countries in our region who will be benefiting from the new support from Gavi in relation to the introduction of the vaccine. Actually, screening infrastructure, the cost of HPV tests, and sometimes, as we have seen in one of the slides, that some countries are really lagging behind for the screening, as well as to have this kind of screening as a routine in their schedule. This is lacking in many countries, and also access to the treatment as the tertiary role or tertiary prevention for rehabilitation is also very costly. We need the management and strengthening this infrastructure in order to be able in the countries, I would say in small number of countries in our region, to be able to do this management in a way that will be able to prevent this cancer cervix. Overall, there are 2 main cross-cutting actions that should be done. In most of our region, we have 18 countries that need really strengthening in their health system to be able to adopt the new introduction of the vaccine, the secondary prevention for the screening, and the third pillar for management. Also, communication, advocacy, and social mobilization specifically for this vaccine is of utmost importance in order to maintain the coverage after being introduction, and we will come to this point at a later stage. This is the situation of the 194 countries in the world, and this has been updated, this map, as per the last year. Every day with new introduction, this map will be updated, and unfortunately, as you can see in EMR region, there is only officially 4 countries who have introduced their vaccine in the routine immunization program, not in a private health sector only, or through NGOs, or through donors, but here we're talking about a routine immunization in the National Immunization Program. Here, we can see the number of the girls not receiving the HPV vaccine by regions. And if we can see this yellow area, which is constituting the 22 countries in EMRO, since the start of 2010, it hasn't been really improved a lot. Because between 2010, when the vaccine has been introduced first time in Libya, and until 2018, when the vaccine has been introduced in UAE, there is a gap with no movement at all. And since the start of introduction of 2018, the vaccine in the UAE, the movement country by country, year after year, is really very slow. So we are still contributing to the burden of the disease worldwide. However, because of the low coverage, this kind of sector, this yellow sector, is really barely moving. So what we need to do is to see this picture starting 2022 based on the new estimate of the HPV introduction that's going to be finalized by July this year, And for the coming years, these sectors, this yellow sector, diminishing year after year with increasing coverage. Actually, this is really the latest recommendation that we got, and after improving the situation after the last stage recommendation and WHO position paper, talking about moving from the 2 doses with an interval of at least 6 months, with no maximum interval, to 1 dose. And here is actually a game changer. This is very important for our countries in the region, at least for the 18 countries, because of the programmatic cost. So this programmatic cost will really very much reduce, with more than 40% of the cost, because of utilizing this 1 dose, in addition to the other benefit of having 1 dose regimen. But this is actually a game changer. And based on this recommendation, which have been elaborated in the last months of the last year, we are trying now to advocate the countries to address our message to the policymaker to start looking at the HPV introduction in another angle, which is the cost. Actually, I am not hiding, but we are doing a lot of efforts in our country for introduction of this vaccine. And after we got some approval, unfortunately, from the Ministry of Health in some of the country, it has been stopped from the Ministry of Finance. So here we are talking about the cost of the vaccine, which is #1 barrier for us for these vaccine, for the middle income country, for the low income countries. So here we are talking about a very important vaccine that will alter the shape of this cancer cervix elimination strategy in, I would say, in the next 10, 15 years and mostly afterwards. But we still need a lot of support from all donors when talking to the country, to the policy maker, not only at the health, but also at the financial level, because when it comes to cost, it is not in the hand of the Ministry of Health to determine that. There are some kind of important consideration that this vaccine is not a regular vaccine. All the routine immunization program is dealing with vaccine in the childhood, and mainly in some other countries is expanding to the school age. Some other countries are going beyond adolescence with more refined immunization schedule of influenza vaccine and other. But still, this HPV vaccine is different one. It is still an expensive vaccine, knowing that the price of vaccine has gone low. The manufacturers are really competing with enough supply nowadays. The price is really depending on negotiation between the country and the manufacturer on one hand. For the UNICEF procuring countries, there is a specific deal with a low price. The Gavi price is really very low, but the operational cost is still very high. So all in all, to have the vaccine is good, but to get the vaccination done, it has a kind of a significant and substantial cost. These vaccines need strong advocacy at the decision maker level. Not only that, but it needs also the community engagement. These vaccines, to have a successful introduction in the routine immunization program, it should have an community engagement. Why we need this? Because this vaccine, in one of its special consideration, it's not a vaccine that will be happy to be introduced in the routine immunization schedule and that's it. This vaccine, unless it have a high coverage in the community, it will not provide its impacts in the years to come. So we need to start with a very high routine immunization coverage since the beginning. And I can tell you example from the world. In European countries that have started the vaccine more than 10, 15 years back. And because they started at 62% coverage, today, after 15 years of introduction, they are stuck with 70% coverage, which is really low for such a vaccine. That's why we need, when we start with introducing this vaccine, we need to start high. And this is a lesson learned. And we are providing this piece of information to the routine immunization program managers. That's why we need to start high. And here today, we will have a very strong country that has introduced this vaccine, and we will get some reflection. Also, this vaccine is a gender-based vaccine. What does this mean? It means that for the first time, we are trying to say that this is a vaccine which has an impact or to be introduced in a specific, not only age, but category of the population, which is girls. And here the people start, why? We are not able to introduce it like it happened, for example, in Australia, boys and girls. Some other country, high-income country, are trying nowadays to get it for girls and boys because they don't have a problem. But for the other country, when we say that we need the girls by the age of 15 to get vaccinated with one dose, here start the questions, why? So this is a gender-based vaccine. As I mentioned before, countries should be planning their introduction with aiming at a high coverage since the inception of the introduction through quality communication and effective delivery strategy. So from one side, we need to strengthen the health system to be able to deliver a vaccine with a high start. On the other hand, we need to have a very strong communication plan to be coupled with introduction plan for this vaccine in order to get it successfully introduced in the routine immunization. HPV supply situation, very fortunately, is improving, and it has wider product now. 4 vaccines are being pre-qualified. But I'm telling you, since the last year, I have been hearing with 10 manufacturers in China that would be producing the HPV vaccine very soon, knowing that maybe these 10 manufacturers will be able to cover the whole China, but at the end of the day, they will have enough surplus to be providing to the global community. So at this time, 4 available vaccines, pre-qualified, and 2 vaccines under pre-qualification while waiting for other vaccines to come. And when this vaccine will come, it will have a high impact on the cost of the vaccine as a part of the cost of the vaccination. So this will help us more in communicating with the country to advocate for introduction of this vaccine. As I mentioned quickly before, we are very lucky that this year we have 5 among 6 middle-income countries in the region that are going to be benefiting from the support of Gavi in 2 aspects. One aspect related to the cost of the vaccine. Number 2, related to what is called WEBi or Vaccine Introduction Grant. It's a 1-year, one-time support to introduce the vaccine, because as we know, when we have a new vaccine in the routine immunization program, we have a specific one-time additional cost that has to be considered by the health system. That's why Gavi is also supporting these countries to help them to start. But on the other hand, the country has a very important role to start having a very strong introduction plan with a very strong strategy of reaching those girls. And here we have different strategy, either a school-based strategy, which is the most successful one. We have a health facility-based strategy or a mixed strategy. So the country should think which strategy should be the most beneficial in order to have this vaccine introduced with high coverage since day one. These countries, these are the 4 countries in green, starting with Libya more than 10 years back, but unfortunately with interrupted vaccination because the context of Libya nowadays. Morocco, Saudi Arabia, and UAE have been introducing this vaccine. Now we are working with 2 other high-income countries without mentioning the name, because we are still didn't have the strong confirmation that this vaccine will be introduced in the immunization program. We have a number of countries here in red. They have the vaccine in country, but they have it in the private sectors. That's why we are still coloring them in red, because when we are talking about introduction of the vaccine, we are talking introduction of the vaccine in the routine immunization program, not in the private health sector or not in a specific category of the population. This vaccine is now active among a specific high-risk group in one of the high-income countries in the region, but we are still not considering that the vaccine is introduced in the countries. We have been working closely with all the countries. We have been launching many awareness campaigns, many webinars at the regional level, and this is an example of one of the webinars that has been lately launched with 2 of the countries that have been sharing their experience, starting their roadmap for the vaccination. Unfortunately, today we have Dr. Ben Azouz from Morocco, who has previously shared also with Dr. Muslim from Saudi Arabia in giving us a situation analysis of their work prior to the introduction and throughout the introduction. And soon, inshallah, we'll get from them a kind of evaluation of the experience of introducing this vaccine. This is a kind of very rapid snapshot of the countries working. This is actually the dashboard of the vaccine introduction since 2018 from the UAE, and this vaccine dashboard provide us with more information about the categorization, about the location, about everything. But unfortunately, this, as you see, that the coverage is at a very low level, but we are hoping with more support, with more lesson learned, the vaccine is coming more and more high. We got a higher introduction coverage in 2021, and soon by the mid 2023, we will get the finalized data from all the globe and from our 22 countries related to the HPV introduction this last year, 2022. Also, this is a snapshot of what happened in the Ministry of Health of Saudi Arabia, about their target, about their program type, about the start of the vaccination, about the type of the vaccination used. And this is a very important element that I didn't go through because it is highly technical related to the choice of the vaccine. So here, Saudi Arabia has been choosing the quadrivalent vaccine, Morocco as well, some other country, UAE. However, we have some countries in the region who have tried to go to the nanovalent vaccine, which is 9-valent vaccine. It is a very expensive vaccine, and it is not supported, for example, by Gavi. So it is really very important to start comparing with the available, either the bivalent, the quadrivalent, or the nanovalent vaccine, to see how much going to a higher level of the vaccine will have an added value to protect again the cancer cervix in the region. This is, I will not take more than 1 second on this slide because Dr. Ben Azouz will be giving us more information related to this, but I acknowledge very much how much work has been done, how much guidelines in different languages for different audiences at all level in Morocco has been done. That's why the preparation in Morocco has been taking more than 1.5 years in order to start strong with this HPV introduction. Many guidelines for decision maker, guidelines for the school-based program, for the community, for everybody, in order to understand how much this is very important. And we have seen more than one time that communication is one of the most important challenge for introducing in this vaccine. And I'm telling everyone, without having a separate HPV introduction plan, to have a separate communication plan, we will not be able to achieve our goal. So communication is very important in introducing this vaccine. To conclude, HPV introduction EMR, not on the target to reach a 2030 target. We can see that the advance is very slow. Countries should plan introduction carefully, aim for high coverage since the beginning. Quality communication, effective delivery strategy. We should be thinking, what strategy to adopt? This is not vaccine that's gonna be implemented through a campaign. It should be implemented through a robust, strong health system, standing behind this vaccine, not for 1 year, not for 2 years, but for life. And they should be starting very strongly in the beginning. HPV supply is improving day after day, year under year, and then the cost will be going down. Actually, we don't know exactly how much the cost will be going down. This is a kind of a cost-effectiveness analysis and the cost analysis, and it's a lot of information related to this, related to the different pharma, different manufacturers that we are not really aware, but we can guarantee with more vaccine coming on the market, the lower the price will be available, more countries will be introducing the vaccine. HPV schedule flexibility is an asset to establish sustainable, effective program to reach the high coverage. So you should be selecting your cohort among the girls to be sure that this will be the effective strategy to reach the highest number of girls, to have the highest coverage starting from the year. What EMRO is providing us? We are providing the regional advocacy webinar in 2023. The regional advocacy country country by country. We are supporting the National Immunization Technical Advisory Group for evidence-based decision for the HPV introduction, and this is country-based. So we are happy to support the NITAG of any country in order to make this decision. We are also technically supporting for Gavi application for HPV introduction, knowing that to get the support from Gavi, we need to provide a Gavi application, which is a long application, which have a lot of details. So we are supporting also in providing this Gavi application to Gavi in order to be able to get the financial support. The country specific, we have a partner coordination for advocacy and communication in relation to the peculiarity of this vaccine in the country context. We are doing the stakeholder coordination with all stakeholders. We are open to communicate and coordinate with all types of organization. We are also in communication with an organization talking about the HPV in high-income countries, in middle-income countries. We are open to support any NGO, any CSO in any country in order to support the decision. We are considering the recent stage recommendation for one-dose regimen, so we are supporting this to go to the decision maker in order to make them understanding that this is actually a one-dose vaccination, and we explore more Gavi to support the introduction of the vaccine. For the country-specific support situation, Gavi eligible country, we have 7 countries in the region. Now we have 3 countries who have introduced their HPV willing to be introduced in what is called full portfolio planning. It's a whole portfolio planning. These countries has addressed that they need to introduce the vaccine by 2024. Although to get the vaccine through Gavi, it would need more than a year to get it. So we need to finalize the application for Gavi 2024 to get the vaccine in country 2025. For high-income countries, Kuwait has started in the private sector. Hopefully, in April, we will have it in the National Immunization Program. Qatar is awaiting ministerial approval to finalize the introduction in the routine immunization program. Bahrain has mentioned that we're going to introduce it this year. However, there is some kind of formality and administrative issue that need to be fixed before introducing this vaccine. The middle-income countries, actually in Tunisia, we are awaiting ministerial approval in order to finalize the decision to have this vaccine introduced in Tunisia. For Egypt, Lebanon, Iran, and Palestine, which are the 4 remaining out of the 5 countries that now are eligible for Gavi support for middle-income countries, they have yet to start. So it's a lot of work to be paid in order to support those middle-income countries. And from this forum, I'm saying that we are open to have all support needed from all organizations, from the global community in order to support the countries to introduce this vaccine as soon as we can. At the end, I thank you very much for your patience, for the time, and looking forward to respond to any question. Thank you very much.
Thank you so much, Dr. Kamal, for very detailed presentation. And I think key messages and positive messages that we learned from your presentation and from the Professor Marian, that now we can still send the message of the possibility of eliminating the cervical cancer. A single dose of vaccine open a hope, and also self-collection of HPV for screening again, like provide an opportunity to scale up the screening program. So now we are going to listen to Dr. Mohammed bin Azzouz, and Dr. Mohammed will share with us the Morocco experience. And he has been working for the immunization program in Morocco for a quite long time. And currently he is the head of he is the head of the Child Health Protection Department and acting immunization program manager. So he will bring us for practical steps for introduction of vaccine from the theory to action. We are going to listen to Dr. Mohammed. Dr. Mohammed is going to present in French, so you have the you have the icon for translation. So please, if you need to listen in English, switch for English using this icon. Yeah. So floor is yours, Dr. Mohammed.
Okay, thank you very much. شكرا جزيلا. Merci beaucoup, Dr Nada, merci à l'Infnet de nous avoir invités à cette réunion importante. Je vais essayer de parler lentement pour que les traducteurs peuvent assurer la traduction dans de bons termes. Voilà, je vais commencer par le partage d'écran. Je vais le faire tout de suite. It's okay? It's okay, Dr. Nada? OK.
You can see your slide. Go ahead, please.
OK. Merci beaucoup. Alors, je m'excuse d'avoir communiqué en français, mais les slides seront en anglais. Comme ça, le contenu soit clair pour tout le monde. Alors, tout d'abord, c'est une belle expérience pour moi de partager avec vous l'expérience du Maroc en termes d'introduction du vaccin anti-HPV. On va s'étaler sur des aspects pratiques, documentant notre expérience. D'abord, de quoi on parle? Au Maroc, on a plus de 13 millions de femmes qui sont âgées de plus de 15 ans et qui sont susceptibles, qui ont un risque de développer le cancer du col de l'utérus, malheureusement. Et aussi, au Maroc, on enregistre plus de 3300 nouveaux cas de cancer du col de l'utérus, avec malheureusement plus de 2000 décès qui sont imputables au cancer du col de l'utérus qui sont enregistrés chaque année. Et chaque fois, lorsqu'on parle de décès, on parle bien sûr de drame social à tous les niveaux. Le cancer du col de l'utérus est le troisième cancer féminin chez la femme au Maroc. 8,1% des femmes en souffrent, avec une incidence qui avoisine les 9,5 nouveaux cas pour 100 000 femmes. Et ça demeure un chiffre important pour nous. Plusieurs études ont été réalisées pour toucher la question de prévalence du cancer de l'utérus au Maroc, mais ces études ne donnent pas de conclusions atténuantes ou des conclusions très claires sur le poids de la maladie et son incidence chez la population marocaine. Mais bien sûr, ça dépend du niveau cytologique au moment de la réalisation de ces enquêtes-là et aussi de la présence ou non d'autres facteurs, notamment l'immunodéficience. Ce qui est important à dire, c'est qu'en absence d'intervention en termes de santé publique, les chiffres, malheureusement, risquent d'être plus alarmants et on peut s'attendre à l'horizon de 2030 à plus de 4 900 décès, plutôt de nouveaux cas qui sont enregistrés chaque année, ce qui est un chiffre très, très grave et qui nous impose à mettre en place des mesures de santé publique et des mesures spécifiques. Donc, à cet effet, comme la slide qui a été présentée tout à l'heure par Dr Kamal, le ministère de la Santé a développé dans ses stratégies et il a insisté sur l'intérêt d'introduction de la vaccination contre le HPV dans le programme de vaccination de façon systémique. Ça a commencé depuis l'année 2010, où déjà dans la première version du plan cancer, on a évoqué l'intérêt d'introduire cette vaccination. Il y a le plan d'action du ministère de la Santé à l'horizon de 2025, le plan cancer 2020 et 2029 qui a recommandé l'introduction de vaccins contre le HPV dans le calendrier national d'immunisation et aussi la déclaration du gouvernemental pour la période 2022 et qui a déclaré de manière claire que le gouvernement marocain va mettre tous les moyens nécessaires pour introduire cette vaccination de façon continue dans le programme de vaccination, vu l'intérêt et sa portée de santé publique. Alors, je ne vais pas me répéter à ce qui a été dit tout à l'heure concernant la stratégie globale et qui vise à atteindre une incidence inférieure à 4 000, plutôt à 4 cas par 100 000 femmes années à l'horizon de 2030. Et je rappelle que le chiffre actuel chez nous, il est aux alentours de 9,2 points. C'est-à-dire qu'il nous faut beaucoup d'efforts pour réduire cette incidence annuelle. Bien sûr, cette stratégie a été reconnue par le ministère de la Santé marocain et a été apportée, et ça représente effectivement notre vision actuelle, et nous sommes inscrits dans cette vision mondiale qui est d'assurer une vaccination de plus de 90% de la population éligible, assurer le dépistage pour plus de 70% des femmes qui ont été avec des moyens de diagnostic qui sont bien précis et bien déterminés, et aussi assurer la prise en charge adéquate de plus de 90% des femmes détectées. À cet effet, nous avons mis en place un certain nombre de mesures. La première, déjà, ça remonte depuis 2010, la date de la réunion, des premières réunions du comité technique de vaccination qui a recommandé d'introduire cette vaccination-là. De même, dans la même année, c'est-à-dire qu'en 2010 aussi, le comité technique a approuvé l'intérêt d'introduire cette vaccination-là, et on a commencé depuis 2018 à préparer, avec l'appui de l'OMS, un plan d'introduction de cette vaccination avec le développement d'un plan de communication spécifique. En octobre 2021, on a pu avoir les fonds nécessaires du ministère des Finances pour l'acquisition de ce vaccin-là, qui a été malheureusement, dont le lancement a été retardé suite à la pandémie de la COVID-19. L'année passée, l'année 2022, nous avons accéléré le pas avec la révision de ce plan d'introduction et son adaptation. Il a été présenté au comité technique scientifique et consultatif de vaccination qu'il a validé. Et en septembre 2022, nous avons mis en place tous les moyens nécessaires. Nous avons déployé toutes les ressources avec l'exécution d'un plan de formation au profit des vaccinateurs. Et en octobre 2022, il y a eu ce lancement de cette vaccination de manière systématique dans le calendrier national d'immunisation. Bien sûr, avant de faire ce lancement-là, nous avons réalisé plusieurs études qui concernent l'acceptabilité. Comme ça a été présenté tout à l'heure, cette question d'hésitation à la vaccination et l'acceptabilité représente un défi majeur pour un programme de vaccination contre le HPV. Donc, la première étude en date, ça remonte en 2015, dont les conclusions étaient très encourageantes, et que plus de 76% des mères et plus de 68% des pères sont d'accord pour faire vacciner leurs filles contre le HPV. Mais avec l'avènement de la pandémie de la COVID et tout le dérangement qu'a eu la vaccination et le doute autour de la vaccination qui a été créée par la vaccination contre la COVID-19, nous avons mené en décembre 2021, c'est-à-dire en pleine campagne de vaccination contre le HPV, contre la COVID-19, nous avons réalisé une enquête plus large qui concerne la mesure de la perception de la population ciblée, s'il accepte ou non cette vaccination-là. Donc, c'est avec un échantillon très important qui a touché plus de 1500 personnes. De manière globale, les résultats de cette étude sont très satisfaisants, très suggestifs en termes de conclusion, mais globalement, on peut dire que la population interviewée, on peut la subdiviser en 4 segments. Le premier segment, il représente le segment 1, qui représente 24%. Ce sont le segment des gens qu'on peut les dénommer, ce sont les déconnectés, ce sont les personnes qui n'ont pas d'informations ni sur le vaccin, ni sur le cancer, ni sur la relation sur le cancer et le HPV, et le vaccin contre le HPV. Le deuxième segment, il représente 25%, c'est le 1/4 des personnes interviewées. C'est ce que nous appelons les cuistres. Ce sont des personnes qui prétendent connaisseurs de tout, et parfois ils prétendent qu'ils connaissent que il y a des vaccins à tous, c'est-à-dire qu'ils ont de l'information, beaucoup d'informations, mais de l'information qui est désordonnée, qui n'est pas structurée. Le troisième segment qui représente les 19%, ce sont les inquiets, ce sont les personnes qui veulent faire vacciner leur fille, mais qui sont inquiètes. Et ces personnes cherchent à avoir beaucoup d'informations pour s'assurer que le vaccin elle est bon et que c'est-à-dire qu'il est sûr, qu'il est efficace et qu'il n'y aura pas de des répercussions négatives de ce vaccin sur la santé des filles, notamment à long terme. Le quatrième segment, ce sont les sereins, ça représente le 33%. Ce sont les personnes qui ont des idées claires et qui acceptent de manière délibérée de faire vacciner leurs enfants. Alors, je partage avec vous quelques conclusions importantes dégagées de cette étude. C'est que lorsqu'on a posé une question sur les causes probables du cancer du col de l'utérus, quand vous voyez, plus de 37% ils considèrent que l'origine du cancer du col, ce sont les relations sexuelles. 26%, c'est le manque d'hygiène. Et uniquement 1% des personnes interviewées, ils considèrent que le virus HPV est responsable du cancer de l'utérus. La deuxième question, elle est en relation avec les moyens de prévention potentiel contre le cancer du col de l'utérus. La majorité, ils considèrent que juste une bonne hygiène intime peut faire l'affaire, de même qu'une bonne hygiène alimentaire, alors que uniquement 4%, ils considèrent que la vaccination représente un moyen de prévention contre le cancer du col de l'utérus. Cela montre de manière très claire qu'il y a une méconnaissance du virus, une méconnaissance du cancer de l'utérus et aussi une méconnaissance importante de le rôle que pourrait jouer la vaccination pour lutter contre le cancer de l'utérus. Et cela nous a donné plusieurs pistes que nous avons utilisées pour la communication. Alors, concernant l'acceptation de la vaccination, de manière globale, 54% des personnes interviewées acceptent de faire vacciner leur fille et que 12% n'envisageraient jamais et pas du tout de faire vacciner leur fille, alors que les autres, 24% des personnes interviewées sont hésitantes et demandent juste d'être éclairées avec plus d'informations pertinentes et adaptées pour qu'ils prennent une décision concernant la vaccination de leur fille. Concernant les hypothèses sur les freins de la vaccination, nous avons eu plusieurs informations. Vraiment, c'est magnifique comme base de données. D'abord, c'est que les parents pensent qu'il y a un effet à long terme que peut induire le vaccin, notamment en induisant la stérilité, problèmes de santé chez la fille. Cela a été mentionné chez 29% des personnes interviewées. 18% pensent que le vaccin peut peut toucher de manière négative la croissance de leurs enfants. Donc, en conclusion, il y a beaucoup de méconnaissances concernant les vaccins et les moyens de prévention. Alors, les deux dernières questions sur le rôle que pourrait jouer l'école dans cette campagne de vaccination. Plus de 89% trouvent qu'il serait intéressant de sensibiliser les filles dans les écoles, alors que plus de 61% considèrent que l'hôpital ou le centre de santé pourrait être le moyen le plus pertinent, le plus adéquat pour assurer cette question pour réaliser cette opération de vaccination. Cela, bien sûr, s'est répercuté sur le design de notre stratégie de vaccination. Est-ce que c'est école ou centre de santé? Alors, comme j'ai dit tout à l'heure, c'est-à-dire qu'en 2022, nous avons révisé notre plan national d'introduction et ce plan a été présenté au comité technique pour le valider. Généralement et globalement, ce plan, il touche 5 domaines stratégiques importants. Le premier concerne l'approvisionnement et la chaîne de froid. Le deuxième, c'est la formation et la qualité des prestations à fournir. Le troisième domaine stratégique, c'est la gouvernance de ce plan. Le quatrième volet ou domaine, c'est le suivi et le monitorage de l'action. Et le cinquième volet, qui est aussi important que le 4 précédent, c'est la communication et la mobilisation sociale pour la vaccination. Je rappelle que notre stratégie vaccinale cancer l'IFI âgé de 11 ans et que la vaccination, elle est actuellement assurée dans les centres de santé comme une phase transitoire parce que dans le document stratégique que nous avons adopté une stratégie mixte. Mais pour le lancement en post-Covid, nous avons réfléchi à mettre en place tous les garanties pour assurer ce lancement de cette vaccination dans de très bonnes conditions. Et on a opté pour son lancement à la faire au niveau des établissements de soins de santé primaires. Le lancement, comme j'ai dit tout à l'heure, a été effectué en octobre 2022 et le calendrier que nous avons retenu, c'est un schéma vaccinal de 2 doses avec le vaccin quadrivalent. Bien sûr, suite à l'avènement des nouvelles recommandations de l'OMS, on se prépare à la tenue d'une réunion dans les prochaines semaines, à une réunion du comité technique de vaccination pour réexaminer notre schéma vaccinal, notamment ce schéma avec une seule dose. Ça va être étudié au sein du comité technique. Alors, ce que nous avons fait, nous avons préparé un programme de formation. C'est un programme qui est global, qui touche tous les aspects qui concernent cette introduction-là. Et nous avons établi un guide pratique de la vaccination au profit des vaccinateurs. Et nous avons préparé avec l'implication des partenaires, notamment le ministère de l'Éducation nationale. Nous avons tenu plusieurs réunions de préparation et nous avons établi une circulaire conjointe entre les deux ministères pour bien organiser cette opération. Et nous avons mis en place un plan de monitoring et un cadre de suivi de cette vaccination-là pour assurer un bon décalage. Quand vous voyez ici, ce sont des copies des circulaires qui sont établies, la circulaire du lancement et la circulaire conjointe entre le ministère de l'Éducation nationale et le ministère de la Santé. Et comme vous voyez, ce sont des images, des documents qui sont produits, notamment le guide sur pratique de vaccination-là et un certain nombre de supports comme les foires aux questions, les dépliants, les brochures et les affiches. Je vous remercie pour votre attention.
Thank you so much, Dr. Mohammed, for this sharing the experience from Morocco, and it's really a rich experience that definitely countries in the region that is struggling in introduction of the vaccine could learn a lot from this experience. So thank you for the detailed presentation we received from you all, and we have some questions. Actually, we have a limited time, so we have like a quick answer for the questions, and for the remaining, which we will not manage to, we can share, and we can share in the report the written answer for that. So there is some queries, Professor Marion, about the screening. So, and the recommended diagnostic protocol, if you can see on the either using PCR as recommended by WHO, and which are the targets for HPV type of both high risk and low risk types to be detected, and which are recommended clinical specimen. So if you can elaborate on this, and and hence it is screening also, I will add a question, because in our region and with the limited resources, and also I mean the government side, public health are not yet convinced on the burden about the disease. So the question on which priority strategy to start, screening, blind vaccination, or if any condition to prioritize the intervention to start when tackling HPV. Yes, please.
Hi, in relation to HPV tests, I think the most important part of the question is the target, and we only want to test for the high-risk types that are capable of causing cancer. We certainly don't have a use to test for low-risk types, and I'm not sure what practitioners would do with those results. In terms of selecting a test, there are a number of PCR tests that are available. And you should be looking for those tests that are clinically validated, and that means that they've been shown to be effective for the detection of precancerous abnormalities. These tests are a little bit different from other PCR tests. They have an artificially constructed threshold to balance sensitivity with specificity. So this clinical validation is really important. So in addition to looking for WHO pre-qualified tests, I will just let you know that the UNITAID landscape document on secondary prevention is under review and will be updated from the 2019 document, which is now quite out of date, will be published probably the middle part of this year. And that gives specific guidance about detecting an HPV test. So I would refer member states to that document as soon as it's available for selection of tests, taking account of a whole range of parameters, which time doesn't allow me to go into now. In terms of choosing strategies, I think it's important to acknowledge that the strong recommendation is that both screening and vaccination need to go hand in hand if we're really to have control of this cancer. There is a planning tool that has been made available partly with WHO support, in which countries can look at modeling in their specific context, look at outcomes that would happen in their country if they chose one approach versus another, if they vaccinated girls with catch-up or girls and boys, how they're screening, etc. And perhaps I could send you some information about that tool that is becoming available to send to member states. WHO is involved in its development, and I've been privileged to see some of the early demonstrations, so that will help countries with not only figuring out their approach, but also will give specific return on investment and some of the information needed to make the investment case.
Thank you, and we are looking for receiving this document, and we will make sure that we will disseminate for all the attendees and the countries that we are working with. So, Dr. Muhammad, there is the question about considering the one dose in Morocco's program, and we are looking for Morocco as a model now applying in the region. So how you see the using this, and also some details on the reasons of parents not accepting the vaccine.
OK, merci beaucoup pour cette question-là. Alors, concernant une dose, c'est vrai, c'est une solution programmatique importante. Ça va réduire les coûts sur plusieurs échelles. Et ça va assurer une rentabilité très importante pour un programme de vaccination. Donc, une dose, c'est toujours compliqué à le faire pour relancer les filles, etc. À cet effet, comme j'ai dit tout à l'heure, dans notre schéma actuel, c'est un schéma à 2 doses, mais nous avons programmé pour les prochaines semaines une réunion du comité technique de vaccination pour retenir ce schéma à 1 dose. Il y a actuellement tous les éléments qui sont en faveur. D'ailleurs, le tableau clair et l'information actuellement diffusée est disponible concernant le niveau d'efficacité d'une dose, quoique il y a encore une discussion sur la durée de protection, mais quand même on peut considérer que les deux, la durée de protection et le niveau aussi de protection sont suffisants pour introduire cette vaccination. Nous sommes en train de se pencher sur ça et probablement on va switcher vers un schéma d'une dose. Alors ça, c'est de 1. Concernant la deuxième question qui concerne l'acceptabilité, Bon, comme vous savez très bien, la pandémie de la Covid a vraiment secoué de manière très négative la confiance de la population vis-à-vis des vaccins de façon globale. Non seulement le vaccin contre le HPV. Maintenant, les gens qui cherchent de l'information, et malheureusement, ils puisent, ils sont confrontés à avoir plus la désinformation que la bonne information. Là, c'est notre rôle. Alors, pourquoi les gens refusent, comme j'ai partagé avec vous tout à l'heure? C'est d'abord, nous avons constaté que la majorité des gens n'ont pas de connaissances solides et scientifiques sur le cancer, sur ses causes et la relation qui existe entre cancer et le HPV. Donc, pour eux, le cancer, il est dû à autre chose, pas un virus. Donc, il y a un chemin à parcourir en termes d'amélioration de la connaissance de la population. Je pense que c'est une demande légitime de la population, c'est qu'ils demandent à être informés. Nous avons mis en place un certain nombre de plateformes de communication pour expliquer de manière simple et de manière adaptée, avec un langage compris par la population là, pour expliquer l'intérêt de la vaccination, mais aussi démystifier ce vaccin, parce que, comme ça a été bien dit, c'est une vaccination un petit peu particulière, ça concerne les filles en premier lieu, ça concerne une catégorie d'âge bien définie, et les parents sont frustrés quand à la sécurité de ce vaccin à long terme. Est-ce qu'il pourra induire de la stérilité, des problèmes de croissance, etc. Donc, les gens posent des questions et de notre devoir, c'est de répondre de manière adaptée et de manière réactive dans un exercice de mobilisation sociale où il y a une intégration de toutes les parties prenantes, le secteur public, le secteur libéral, de tous les intervenants, de l'enseignement aussi, c'est un partenaire important parce que les instituteurs sont considérés vraiment, ce sont les seconds parents, et ils sont très bien écoutés par les filles et par la communauté. Donc, on est dans un travail d'éclaircissement des idées. Comme ça, les gens seront convaincus. Donc, on est conscient de ça. Historiquement, il y a un héritage de vaccination dans notre population, à l'image de plusieurs pays à revenus intermédiaires. Donc, on vaccine bien. Généralement, les autres vaccins sont bien acceptés, très bien demandés, très bien, avec des taux de couverture vraiment élevés. Donc, juste la population, elle est dans un droit de demander des informations et nous sommes en train de meubler tous ces points-là et de combler ces lacunes d'information. Voilà. Merci.
Thank you, Dr. Muhammad, for your answer. And I have one question for Dr. Kamal regarding in our discussion with the NI tax. The NI tax actually in guiding countries also, they are struggling with this gap in information. So what's your advice in that? I mean, from where do we need to wait till we get collect data, do studies, or how can we move around that, especially when we look for the indicators that the mortality is high. So it's clear that there is burden not documented. So please, Dr. Kamal, if you can.
Yeah, thank you very much, Dr. Nada. Actually, as I mentioned, one of the support offered from the regional office is to support the NITAG decision. And actually, we have a couple of meetings in the next couple of months, how to support the NITAG to what is called evidence for recommendation. So in order to reach the recommendation or a decision, there is a pathway to follow based on the available information. Sometimes we can get the information global wide and build our decision as it happened in all the countries. And sometimes we depend on the local estimate that we have. As you know, the latest estimate for the cancer cervix is coming from the GloboCan 2020, which is from the International Agency on Research of Cancer from WHO. This is the most official data that it is available global-wide and used by every donor and partner to support the cancer cervix elimination strategy. However, some other countries are conducting local studies. They are conducting local issues. So they can use it, either study, either survey, or whatever the document that they can use in order to reach the decision. In case of lack of information in the country, we sometimes offer the NITAG to use the information which is available in neighboring country with the same contact, same population structure in order to reach the decision. Because as you've said, in order to go for a specific survey or study to get the documentation, it would take another year or more than a year to have this problem. So either we depend on retrospective analysis of actual situation in the country, which would take a couple of months, or we depend on available data, whether the regionally or the global one.
Thank you. And we are looking for the impact of this deliberation with the NITAG in the upcoming weeks, so to have the impact in the region, especially that we are lagging behind. So actually the time for the webinar already we finished the time, but I have one burning question. I need like a quick 2 minutes from each of the panelists now we have some I don't want to say reluctancy from the government, I mean from the public health, since there is no enough data and competing priority to take initiative regarding the cervical cancer. So how can the other players within the country, I mean the CSOs, academia, and private sector could play a role on to achieve the target on relation to cervical cancer? So if you can give me a few insights from your experience on that.
I might just jump in and say that there's such an important role for advocacy here. This is a matter of political will. We've got the tools and we know that they're cost effective, and in the long run, they will save the government money. So we really need civil society to be advocating for the right to access important healthcare. And I'll just finish by saying that the HIV community didn't get all the access that is transforming that disease to antiretrovirals and so on by asking politely. We have to stand up and start demanding the rights of women and girls to be free of this preventable disease. Thank you.
Thank you. Thank you. So Dr. Kamal, if you can.
Yes, sure, the academia has a very important role. The CSOs, NGOs have a very important role to support the advocacy at all levels. And as I mentioned before, we should be directing our advocacy to all decision makers, whether health related or non-health related. So we have heard from Dr. Ben Azouz how the cooperation between the Ministry of Health and Ministry of Education has helped the introduction. On the other hand, I have mentioned the problem of the Ministry of Finance, for example, because this is, at the end of the day, this is the money of the country. So we need really to have a very specialized high-level advocacy in order to make all decision makers making sure that they are investing good money in order to have a good impact, which is reduction in the mortality of a disease that have more than 50% mortality.
Dr. Muhammad, if you can add based on Morocco experience, and especially if the women groups organization, they play any role on Morocco experience? You can't hear me? Or? Yeah.
Oui, actuellement, nous faisons un travail continu de jouer comme une seule équipe. Et c'est pas un exercice simple, c'est-à-dire que se sentir une seule équipe, le secteur public, le secteur privé, les ONG et les différents intervenants. C'est pas un élément facile à faire. On trouvera à un certain moment, comme on dit en français, ce sont des brebis galantes, c'est-à-dire qu'il y a des gens qui vont des sens contraires à celui qui est tracé initialement. Mais un point important, vu notre courte expérience, c'est que il faut prendre en considération les vaccinateurs comme un levier fondamental et les professionnels de santé pour faire réussir la vaccination là. Parce qu'un professionnel de santé non convaincu, il ne va jamais convaincre la classique en termes de formation, mais il faut insister sur l'information et la mobilisation, surtout des professionnels de santé qui sont impliqués directement dans la vaccination, et je les considère comme une partie prenante et décisive pour la réussite de cette vaccination-là.
Thank you, Dr. Muhammad, Professor Marion, and Dr. Kamal for your time and for this insightful presentation and feedback and what we get. And I'm sure we will reach you out by the question that we will receive from our colleague and from the countries. I'm sure that you can respond. Always you can respond, and we will include your answer in our webinar briefs that we are going to disseminate. So thank you for your participation, for this very insightful and comprehensive informative speech that you shared with us, and for sharing your expertise. And I think it's now we need all to collaborate. It's a time to eliminate cancer and to send this positive spirit in the region, and to push for that. So thank you very much for your time and for your contribution. Thank you.